Hello, this is Kyle Richards, host and creator of WInnovations, the podcast destination which aims to highlight novel and innovative happenings in the world of urology. As we enter Season 4, we'll have more voices behind the microphone. We teased this a bit in Season 3 with an episode that Dr. Frank Lin hosted, but we plan to expand our lineup of hosts for Season 4 as I take more of a behind-the-scenes role. It has always been a pleasure and honor to host and create for this podcast, and I thank all of you, our listeners, for their support, and of course our amazing editor and producer, Sandra Miller, who makes this all sound good. The WInnovations podcast will continue onward, and I look forward to many more educational episodes to come.
The most impactful part of single port robotics is not the single portedness of it, right? That's really not where the magic is. The magic is in regionalization of surgery, and whether that regionalization is in the retroperitoneum or it's in a transvesical approach to the prostate. That's what single port has allowed us to do, is to do that regionalization. It's like the easy button for regionalization. And it's kind of dragged urologists back out of the peritoneal cavity in a way that we haven't seen since the advent of laparoscopy, in the late 1990s. So I think that's really the magic. The magic is that this tool has allowed us to get back out of the peritoneal cavity and regionalize our surgery, and that's where we're seeing all the benefits to the patient.
Welcome to this episode of the WInnovations podcast. I'm Ali Antar. I'm an associate professor at the University of Wisconsin. I'm exceedingly pleased and excited to have two of my most memorable teachers as guests on the episode today. Dr. Link taught me in residency. He's the Carlton-Smith Endowed Chair in Urologic Education at Baylor College of Medicine. He did his residency at Baylor, and he did a fellowship at Hopkins. He's pioneered a lot of tremendous techniques and that I got to witness firsthand as a resident and learn a ton from. And we have with us also Dan Gralnek, an associate professor at the University of Wisconsin, who's been pioneering the enucleation program here at the university since 2016. And it's really grown in a way that I didn't realize it could be. So I came to the University of Wisconsin and learned a whole different technique. And so I learned one from Dr. Link and one from Dr. Gralnek. It's going to be great to talk about the ideas, find the commonalities, and how they really fit in the toolbox, and focus a lot, especially with Dr. Link here, on this single port robotic platform, primarily as a new avenue. Selfishly, I'll admit that a lot of it's for my education and development of ideas and as a sounding board. But thank you both for being here. I'm very honored to be able to speak to you both at the same time in this setting.
Thanks for the invitation.
Great to be here. Nice to meet Dan as well.
Awesome. Amazing. So I think what I would start with, I listened to the episode of Backtable Urology that you had done with Dr. Stifelman, and there were so many profound insights just listening to the way you described your experience with the single port. And I think that probably be the best place to start. What was it like making that transition? Because when I was a chief, you were right on the cusp of making the switch. And we had talked about it like as a dream that we would be able to do transvesical simple prostates. And now it's a pretty routine thing, and there's been a lot of change. So I guess I'll just let you take the floor and tell us a little bit about what that experience has been like, the biggest joys, the hardest challenges.
Sure. Well, so I think the best way to think about this is to think a little bit about the history of minimally invasive surgery in urology and how it's evolved over the years. When I finished my fellowship in 2005, we were doing primarily laparoscopy. And you saw that evolve from laparoscopy into robotics in the mid-2000s, particularly with respect to radical prostatectomy. But then there was this long lull period where we basically just did the same things over and over and over again. I mean, if you look at what I was doing in 2010 versus what I was doing in 2020, it was pretty much the same. And it was a kind of a period of not stagnation, because there was progress, but there wasn't that much innovation in the space at that time. And so when the single port platform came out in 2018, I got very interested in it, although at that time, I think we didn't really know what to do with it. And so there wasn't a lot of things that I felt I was going to use this for. One of those was for simple prostatectomy and also for reconstructive surgery. But honestly, it was remarkably transformative. And I think when you think about transformation in surgery, it's always the transformative things are always where technology and technique or technology and ideas kind of come together. And I think single port is one of those examples of where that's been done most effectively. And I would argue also, HOLEP is one of those where it's been done most effectively, because you have technology that's advanced, a new tool, a new toy, something that can do things you couldn't do easily before. But it only becomes valuable when it gets tied to technique or surgical approaches that are new and novel. So for me, I expected that single port would be a very small piece of my puzzle, but within just a few years, it has kind of taken over. So at this point, I probably do somewhere between 70 and 80% of my minimally invasive surgery with the single port platform, which is completely not what I would have expected in starting. And then the last thing I'd say about it is that, the most impactful part of single port robotics is not the single portedness of it, right? That's really not where the magic is. The magic is in regionalization of surgery, and whether that regionalization is in the retroperitoneum or it's in a transvesical approach to the prostate. That's what single port has allowed us to do, is to do that regionalization. It's like the easy button for regionalization. And it's kind of dragged urologists back out of the peritoneal cavity in a way that we haven't seen since the advent of laparoscopy, in the late 1990s. So I think that that's really the magic. The magic is that this tool has allowed us to get back out of the peritoneal cavity and regionalize our surgery. And that's where we're seeing all the benefits to the patient.
Awesome. The thing about that kind of journey, I mean, you said it was 2018, it's 2026, that's 8 years. And so it's really hard to condense what must have been a very arduous journey. And so you talk about where the magic is. And I think the main question I had with regards to the magic is, when you talk about regionalizing, you had this definition in the episode of Bacterial Urology that you said that we were going to avoid the peritoneum. And that was like a key realization. I started thinking about the definition of endourology, like what separates endourology from other versions of urology. And it's really that idea of, we're going to be able to have a straight shot to the pathology, arrive, intervene, and leave with as little footprint as possible. So was there a moment when it clicked? You're just like, wow, I was right there, and it just became a lot easier for you? And do you remember that moment?
Yeah, I think that we learned in the early or late 2010 range about single port surgery, right? We were doing single port transperitoneal kidney surgery laparoscopically, and as much as I love that approach, we learned that it doesn't really make that much of a difference in terms of patient morbidity. So you can make the argument that the juice really isn't worth the squeeze when it comes to that technology. The difference with the single port robot is, again, the regionalization. So it's a stealthy and efficient method to do surgery. And it really is dramatically better in terms of patient morbidity. And it's so better that it kind of slaps you in the face. So I think those moments of revelation occur, early in your learning curve, where maybe you're just struggling a little bit to get the case done. You're feeling a little uncomfortable. It's a fun journey. It's also kind of an ugly journey, right? Because you're learning to do something that, you don't know how to do, and you are struggling at times. And then to see the patient in the recovery room look so different is really an incredible experience. So, you had a rough day, but your patient looks amazing and wants to go home, right? That experience is just not the experience I had in traditional laparoscopy. In traditional laparoscopy, I was barely getting out of second gear in most of these cases, but the patient struggled a little bit post-operatively. They did not feel great. They stayed in the hospital a day, maybe 2 days. But with the single port approach, that was probably the biggest revelation. And I think the second revelation was inefficiency. The fact that it's so much faster than what you normally do with transperitoneal surgery, that we nowadays will do an extra case in every room a day, just because of that efficiency. And it's not because we're moving faster or doing anything unusual. It's just that we're skipping so many unnecessary steps to accomplish the goal. And so I think those two things together, it's like a perfect handshake. You've got dramatically improved morbidity for patients when you regionalize, combined with higher efficiency. So it's really everybody wins in that scenario. So that's been what's driven its adoption, I think, in our hands, seeing those two things come together.
Yeah. So I think, Dan, I'm going to tell a story about one of the first times I watched your enucleation. Because Dr. Link, you mentioned this thing about technique tied to the technology. That we have all these new technologies, and if we're not tying it to a technique, then the technology sort of just gets wiped away, and it's not really an innovation. And that's really the transformative innovations have both. And I remember the first time I walked into Dan's OR, and I was watching him do an enucleation. I was like, oh my God, he's doing exactly what Link does, but he's doing it with like just the head, with just like and so I was watching the same technique with a completely different technology and a completely different approach. Dan, would you agree to that type of description of the ideas of the technology, of the techniques?
Like Dr. Lincoln was saying, that I agree. The technology certainly improved things like that, and I remember many days that I thought I was having a tough day, and that the patients looked amazing. And when they would come back a week or two later to check in, that sort of kept me going during some of the rough days when I debated, stopping.
It's not just like an anatomical, like two roads to the same place, even like in the outcomes, it's to the same place, but the roads just look different, right? And having had your background, Dr. Link, in the multi-port simple prostatectomy, I feel like really did help me picking up enucleation with a laser. Do you think that your experience with single port nephrectomies and that type of working angle, do you think there was any type of direct translation into single port because of your experience, extensive experience with that? I still have a hard time explaining it to people because it's so unique, the way that you do the single port nephrectomies. Low anterior, yeah.
I think low anterior access is magical. It's also extremely foreign, right? It's a very unusual approach for those of us that were trained to do nephrectomy through a transperitoneal approach. But when it clicks, it is a really powerful technique. And it's powerful mostly because it's the same every time, right? You just do the same thing every time. Same incisions, same landmarks. You're dealing with all bony and muscular landmarks that don't change from person to person. And so if you just stay disciplined and force yourself to set things up the same way every time, it becomes extremely easy and very efficient to get in, get out, to do all the things you need to do. And that isn't always the case with transperitoneal surgery, right? You're dealing with, hostile abdomens or patients that are very obese or patients that are extremely emaciated. They're very different in terms of where the anatomy is. Sometimes the colon's behind the kidney. Sometimes it's in front of the kidney. All of these things kind of get eliminated when you do low anterior access retro, because the structures are the same. Your psoas muscle is always in the same place. Your ASIS is always in the same place. You don't need to move your incision based on patient body habitus. So all of those things are very helpful. It is just initially a little bit of a learning curve for people because it's not a perspective that they've ever been trained in prior to this. Now, today, and again, I hope we'll talk about this later, the residents learn to do this very early, right? And so now for them, it's natural and normal to do low anterior access. And in many ways, they're better at it than we are, right? Because they don't have a bunch of bad habits that they have to unlearn. And that's really gratifying, right? You see that they go into the cases and they're just automatic, right on top of where they need to be. Whereas those of us that spent 2 decades doing, periumbilical access, sometimes we lose our way. So I think that these examples, and I'm very interested to hear what Dr. Gralnek thinks about with HOLAP, that I think these new technologies and techniques together, they are so, they're very teachable to the new generation, and they're going to just adopt them, and it'll be internalized into their armamentarium in a way that it wasn't for us who had to learn it, after we'd already been formed.
Dr. Gralnek.
Agree completely. When I talk to older surgeons and try and talk them through doing something like a HOLAP, a lot of times they're thinking about it as a TURP, and it's the wrong mindset. This is an open, simple prostatectomy that we do in a retrograde fashion with the scope instead. And so it's a very different thought process. But once you have it, like Dr. Link was saying, seeing the residents sort of pick that up, which is usually about case 10 to 12, you can see them suddenly see all the planes that you're looking for. And it is so incredibly gratifying. And then you see how much they enjoy it. And this surgery, at least the hole up, and I assume the simple prostatectomy is the same, where it's really an enjoyable surgery for the surgeon. And then on top of it, you see the outcomes, which are just fantastic.
Yeah, and I think I'll take this back to Dr. Link. You, in the back table episode, you mentioned this thing about the transition when you're making these transitions, these kinds of leaps, that it's like learning a language. And then it cut you off there, and I was like, no, I wanted to hear more. So any more of a deeper dive? And Dan, I think it also hearing your idea about changing that language from TERP to something else, right? So I just wanted Dr. Link maybe just start with, I guess, that idea of learning a language and what it was like and how the residents picked that up a little bit better.
Yeah, I think it's, when you first start something like learning a language, it's such a struggle, right? Every word you have to, search for and think about, and it's a struggle. And often the value is sort of not clear when you're such a beginner at it, right? It's like, but then once you break through a certain point, then the value becomes very evident. And I think that there's a life cycle to any technique. And I think probably of the techniques out there, single port surgery and HOLEP are probably very similar in this way, right? Where it's almost like you're growing up. Initially, you're super excited. Oh, it's a new toy, a new technique. I'm going to do it. And then you rapidly get into that adolescent sort of disgruntled phase where you're struggling, and why do I look so foolish? I can't do this. I don't want to do it anymore. That kind of feeling, right? And then some people are lost at that point, right? They just stop. But then others get through that phase and into the adult phase where you really see the value, right? And I think that for single port specifically, we've lost a lot of people that just got into that early adolescent phase of the technique and just kind of flamed out and didn't push through it. But once you push through it, that's when the real value is evident. And I suspect with HOLEP, is that similar? I mean, in your fifth, sixth case, you got a big prostate and you're just like struggling and you're thinking, this is no fun at all. I'm not doing this anymore. But at some point it just clicks, right?
I agree completely. Not only that, but the other thought that I had was that as I struggled through my first, 20 cases without anybody around that knew what I was doing, it was incredibly helpful once I had a partner that I trained to do it. And once we could sort of talk about it and came up with a language to sort of describe where we were inside the prostate, it really changed. I used to describe it as, instead of just getting through a single case, we started a program where we could teach this, we could break it down into pieces, and it was a very thoughtful thing instead of just the struggle.
Yeah. It's like learning a language, learning in general, the growing up and reaching that adult phase. I think one of the things that happens to enucleation, transurethral, I'm just going to, for the sake of this, I'll keep calling it HOLEP, but I like the idea of transurethral, transvesical, right? And that being the direct opposing force. But one of the things that attached to the reputation of laser enucleation of the prostate early on is this idea of a difficult learning curve. And do you think there's an overlap in that idea of learning curve and this type of learning of a language and in STEP? And what are your ideas about remediating those particular difficult areas or those types of concerns about the difficulty?
With respect to STEP, you mean?
With respect to STEP, yeah.
So, I think that when we first started doing STEP, we had to unlearn a bunch of things. And until we did that, it was a struggle. And I just remember those early days that I basically did the operation like I was doing multi-port single prostatectomy. And, a lot of the things that we did in multi-port don't work in this transvesical world with less strong instruments. So I think that you would have cases that went very smoothly, but then you would have cases that were kind of like a knife fight behind a biker bar, not predictable and very frustrating. So when we unlearned all that stuff and kind of came up with like a recipe to do this because the goal was come up with a recipe that would allow us to do the operation predictably, teach it predictably, do it predictably. So I kind of know what's going to happen on every case every day. And once we got to that point, I think actually teaching STEP is not very difficult. It's actually a pretty good case for resident teaching. We have some advantages with such the technology being so sophisticated, and also with new tools like the forced bipolar that allow us to teach this pretty easily. So it's not uncommon for us to have, the resident early on in their experience, resecting half the adenoma or doing most of the reconstruction, because we do have this advantage that, that we have lots of degrees of freedom, lots of instruments to work with. So it's actually, I think, simpler. I really don't do HOLEP, so I can't really judge on the learning curve, but I don't think that the learning curve for STEP is very long. If you're doing it in the right way, right? So if you see sometimes people doing this procedure and it looks kind of like a fight, right? There's just everything is just being torn and there's bleeding and it's a bit of a mess. And I think that you can't learn to do it that way, right? You have to kind of learn it from the base principles, and then if you stick to those principles, it's really not hard. I think the other thing that STEP has going forward is that it scales very well, right? So if you can do a 120 gram prostate, you can do a 220 gram prostate with STEP without a huge leap in difficulty, as long as you stick to the principles, right? Because essentially you're just rinse and repeating to do a bigger gland. So I think that's one of its strengths, that you can scale it. Now, if you start your learning experience with bad patient selection, then you're going to have a rough time. There's no question about it. But if you do it in an organized manner and stick to your guns, I don't think it's a difficult procedure to learn.
Yeah. So this is an open question to both of you, and it doesn't have to have a final answer because it's just something I debate in my mind eternally. The people who drop off from learning either template, either single port transvesical or laser enucleation, do you think that it's something that's inherent in their learning mode, or is it something that had they had a better teacher, they would have been able to pick it up? Let's open to both. I don't know whoever wants to go first.
I would say that it's usually a frustration, and that if they have a community of people that they can contact with a question or just simple encouragement, that it's really a surprisingly short little hump that they have to get over. But at the time while you're going through it, it feels like a mountain.
Yeah, I think it's two things. One is a little bit your personality, right? And you have to think a little bit about why you're doing it. So what is it that's driving you to take on any new technique? Is it, what's your motivation? And is it a good motivation, like one that has depth to it, or is it a very superficial motivation? I think if your motivation has depth to it, whether that is, a fervent desire to, have better outcomes for your patients, or maybe you want to, you're a novelty junkie like I am, and you want to do something new and you're bored doing what you've been doing all along, or those kinds of things, you're likely to stick with it. And then the second thing is, for anything, you've got to be willing to look foolish, right? You have to be able to be in the operating room, not be absolutely in control of everything and look like a smooth character in all cases. And I think that people that do new things, they either have the ability to just tolerate a little bit of that chaos, but they're willing to, struggle in front of people and make it and carry through. Because we all know surgeons that are extremely good technical surgeons, but they just never get outside their comfort zone. They stick to their one thing or two things, and they like to do the same thing every day, the same story. That's not a person that's going to enjoy learning one of these approaches.
I think I've gotten a satisfactory closure on that topic. And to jump on to another idea that you had mentioned about the reconstruction and struggling with a certain step and looking foolish. And this is going to maybe sound a little bit too personal, but I remember distinctly the one step in the simple prostatectomy that I never was able to perform well in front of you was the reconstruction because it's a lot of that sort of putting it back together. And when I came to Wisconsin and I saw, hold on, they're doing the simple prostatectomy and then no reconstruction, I was like, wow, so the worst part of it is gone. And that definitely drove me to being more open to doing it. But I'm starting to wonder what's the hidden cost, right? And what's the real benefit from that reconstruction? And do you have any insights about, one, the struggle in translating that reconstruction from a multi-port to a single port? And then for you, the benefits that reconstruction gives in these outlet procedures?
Yeah, so I think that the teaching people to do the reconstruction, now that we know how to do it correctly, is not difficult. So it's 20 minutes basically of at most, and that's with the resident doing it. So again, I don't think that's a major hurdle anymore. What we used to do in the multi-port approaches, most of it is unnecessary, right? So I think that just getting the technique down and simplified, there's lots of simplifications that have been done. And I do think, honestly, in many ways, doing the reconstruction with the single port transvesically is in some ways easier once you do it that way. I think the bigger question is it necessary, right? And I think for simple prostatectomy, I personally think it's very valuable to do it. Now, you're not doing exactly the same thing that you're doing in a HOLEP, right? You're using a totally different energy mechanism for doing the procedure. And I don't think that we can make a direct leap to say that since both techniques are enucleative, they both equally benefit or not from reconstruction. We've gone through a series of different stages of this procedure. We initially did transvesical, transabdominal without a reconstruction. And then when we switched to doing a reconstruction, we noticed a pretty significant improvement in bleeding, post-op irritative symptoms, things like that. And I think that we see that in the single port transvesical approach. These are patients that are almost all going home the same day. And if you do a good reconstruction, they definitely have less bleeding and they definitely have less irritative symptoms. Now, does that mean that in some way it's superior to a laser enucleative technique without a reconstruction? I think you're comparing apples and oranges, right? The data for HOLEP is actually is quite a bit stronger out there than the data for single port transvesical simple prostatectomy. So my point is not to say that everybody who gets an enucleation needs a reconstruction, but I do feel strongly that it's an important part of the step procedure. There are some people that don't do it. I don't really understand why. It's mostly kind of an efficiency thing, but really it's not a long part of the procedure. It's often the part that we have the residents do first in that surgery. So now, different story from where we were when we were teaching it to you, right? When you and I were working together, this was a totally different situation. So yeah. I think once you refine the procedure, think about radical prostatectomy. If you were there in the early days when we were doing laparoscopic radical prostatectomy, or even the early robotic days, the anastomosis was a big deal, right? It was a place where lots of bad things happened, and it was technically challenging and frustrating. Today, the anastomosis is kind of the easiest part of the operation, right? It's what the junior resident does half of when you do the surgery. So I think everything evolves over time, and hopefully we learn to do it better and more efficiently, and we can teach it better. So for me personally, I do the reconstruction in every case I can get away with, and I think it does play an important role.
Yeah. Dr. Gralnek, I think the analogy that I always thought of with regards to this reconstruction is whether or not you go back in to do hemostasis after an enucleation. Would you agree, and do you have any insights, further insights to add on to what we had talked about?
So hemostasis after morcellation and morcellation. I always felt that if you had done a good enough job, that maybe you didn't need to do that. Like, certainly, occasionally, after morcellation, an additional 5 to 10 minutes, maybe some small bleeders would be identified that were not prior to that. But for the most part, I found that if you could not go back in with the laser to get hemostasis, it was better. Sometimes I think benign neglect is an underappreciated habit. And if you try and get every single small venous ooze, sometimes you're using more energy and maybe they're having more symptoms, more side effects, more complications. And so I have a goal of trying to send everybody home same day. And I want them to be in that position, whether socially that's an option or not. And so I try not to go back in, but I also don't hesitate that if it needs it, it needs it. So
and that's the thing is here at the University of Wisconsin, it feels like because we have some people doing enucleation that we've sort of formed this camp, post-morcellation hemostasis or not. And some of us tend to fall on one side and others tend on the other side. Dr. Link, do you think there's something similar with reconstruction that's happening on the transvesical enucleation side, where some people are okay with it and they have a similar reasoning versus I really think we should get for everybody?
I guess so. I mean, there are definitely people that do less,
Yeah.
and or even. I mean, no, there aren't too many people doing nothing, but there are some people that are do like a posterior shelf kind of thing. But it's usually just speed, right? And I think that I have a little bit of a problem with that in the sense that we're doing a procedure and we're doing it the way we're doing it to try to bring all the advantages to the patient. And to not do a reconstruction at the end of the procedure seems like you're throwing away one of the primary advantages of transvesical robotics. And so I think it's worth doing. Now, there are going to be some situations, I've done 400 or 500 gram prostates this way. And in some of those cases, trying to do a complete closure is not practical. And you can get away with doing less and they do well. But I think that because it is so relatively straightforward to do the reconstruction, I would not skip it for the sake of 15 to 20 minutes in most cases. Does that mean that everybody who doesn't do it is doing something wrong? No, of course not. I mean, I think everybody has a different experience, but I'm doing this and bringing this to the patient to get all the advantages. And so I'm going to apply all those advantages if I can to the patient.
And I think that's the thing about the camp here that does mostly the repeat hemostasis after morcellation. It actually arised, historically speaking, from a similar motivation about same-day discharge. That this idea, like if we're going to discharge on the same day, we need to give them every single advantage we can before we ship them out the door. Dr. Link, you were the first one. I remember a very distinct time as a chief resident. We sat down, we talked about same-day discharges in the workroom on the 16th floor of St. Luke's Tower. And you talked a lot about the cultural side, the systemic side of same-day discharge, as opposed to it being a characteristic of a technology or a technique. How much do you think that that's still true? How much do you think that's benefited you? Are there variations on that same-day discharges have you seen with single-port transvesical enucleation?
Yeah, I mean, I think I'm sure this is true as well with HOLEP that a lot of same-day discharge is about what you tell the patient before surgery, right? When you have a conversation in the clinic and you just say, well, you'll go home the same day, we'll do this, but that makes it a lot easier to do that. I think that with single port, especially transvesical approaches, there's very little barrier to discharging people because they're just not hurting after the procedure. And so it does make it a little bit easier. We all know examples of programs where they will discharge, for example, transperitoneal multi-port radical prostatectomies the same day. And you can certainly do that. It's a bit of an effort and it involves kind of a system to do that. But I think that your patients are not feeling that well when they go home. They can probably do it successfully. With single port, whether you're doing transvesical surgery or extraperitoneal prostate surgery, they usually feel pretty good after the procedure and are pretty happy to go home in most cases. Again, we discharge about 85% of our STEP patients, and the ones that stay are almost exclusively for sort of social reasons, like long distance drives or elderly I mean, I'm talking about discharging people in their mid 80s. We do that all the time. But again, case starts later in the day. It's like the fourth case, and they're going to be getting out of the hospital at 7 p.m. or something like that. Those are generally the reasons that we keep people, rather than for medical reasons like bleeding. I mean, we never use CBI in these patients. They don't have three-way catheters. So generally, it's a social thing. So I think that some of that is perhaps made a little bit more practical by doing the reconstruction. I don't think that doing cautery-based surgery is exactly the same as doing laser-based surgery. I think we've sort of proven that in the laser nucleative world, where doing that in the setting of anticoagulation is feasible in some cases. I don't think we would be doing that simple prostatectomies on fully anticoagulated patients. I think that would not go well. So there's definitely a difference between the two techniques, and I can only really speak to STEP that with that approach, the reconstruction seems to matter.
And I think the idea of the same day discharge, what you tell the patients, and having them set up for it is super important. And so then if you're never having to set them up for CBI, because that's actually one of the things that we still have a hard time setting up patients for in terms of the conversations, is like, okay, we're going to watch this catheter, it gets bloody again. That's really the thing that always, it's been holding it up a lot. And for me, because I know that it causes so much tension, actually now when I do these at the VA, it's an automatic admit overnight. It feels a little bit more like the Mokira type TERP approach, where everybody gets that overnight admit just to tuck them, make sure all their concerns are answered. And that's what you've told them beforehand. And that sort of leads to the successful discharge where they feel happy and they don't feel, bothered by the effects and the risks from the surgery itself. On the same topic of extra steps, one of the things that you'd mentioned on the Back Table podcast was the idea of ejaculation sparing, enucleation transvesically. What have been the developments there? Is that something that you do now offer regularly to your patients, or is it still in the development?
So I think what we do technically is is a little bit similar to what's done, for example, in aquablation in terms of preservation. I don't advertise that to patients yet. I think that's not really, we don't have the data to support a statement that says, such and such percentage has antegrade ejaculation after this procedure. I think that, though, that we have all these tools in this setting, right? We're definitely at an advantage versus sort of a few degrees of freedom with a laser fiber, in the sense that we can preserve things. So part of the newest way that we do this, it involves sparing that posterior strip, basically, of tissue, and that has a lot of benefits in the sense that it really does make the reconstruction much quicker and easier if you spare that strip than if you just do it the way we used to do it in multi-port. And I think that we are seeing patients that have some preserved antegrade ejaculation in that. I don't think it's quite ready for prime time, in the sense that when I counsel patients on BPH therapy, I always discuss low ejaculatory volume or no ejaculatory volume in setting of this surgery. And then if they happen to have antegrade ejaculation afterwards, it's a nice surprise. But I don't think we should be selling this to them as that technique. But in the future, I don't see why this can't be further refined and tested, because we're not limited by what we can do. I mean, we can preserve whatever we want to preserve if we wish to do so. So I think that there's a lot of potential to improve this operation. As it is, the way we do it with the posterior strip just makes the apex easier and the reconstruction easier, and it's just a good technique for that purpose.
Dan, you've been experimenting a bit with partial enucleation and some of these modified templates. What are your thoughts on the future of ejaculation sparing in enucleation, if it's worth that kind of refinement, and any ideas on your end?
My only concern with it is that there's a vast difference between different techniques that people are doing for ejaculation sparing, and trying to compare things to get a true outcome has been, I think, more difficult. We've been doing quite a bit of it with the laser. I think that as you come from a retrograde approach, you see it directly. You can see the ejaculatory ducts easily, and so it's easy to spare them and to work everything around there. And I've been very pleased with the ones that we've done. I think there's a big question of size. At what point is it going to be more difficult to do? Certainly once we get into the 200 plus gram, I think that trying to do something with ejaculation sparing may be much more difficult to successfully do.
All right. I don't know if I should be sharing these kinds of ideas, but it's been my dream ever since we talked about the idea of transvesical when I was a chief, Dr. Link. But it's this idea of the two-way. Is there any value to the ejaculation sparing template start with the laser transurethral, and then completion transvesically to pull the rest of that out, because I would imagine also that without the concerns about morcellation, that evacuating the specimen tends to be a lot more straightforward through a transvesical incision. I guess open question to both of you about that type of idea of a two-sided approach to the really large prostates to also incorporate ejaculation sparing.
So there are quite a few people doing those types of things, and it's very interesting. Obviously, it's not maybe the most cost-effective way to handle this problem. And I think that a lot of people that do that are doing it because of a perception that it eases the apex dissection. I don't really think that's the reason to do it, especially if you do the splitting method. The apex is not difficult to manage at all. I don't think that's the issue. However, doing it in some fashion to aid in ejaculatory sparing might be very interesting. So doing a combined approach like that is, it's being done and it's being tested. I think that you have to find a good reason to do it to justify the expense. You can do it simultaneously because patients can be in lithotomy and have the single port robot docked and do stuff transurethral at the same time. So lots of interesting options there. But doing something, if your view of the ejaculatory duct is better from a retrograde approach, maybe there's some utility in doing that. So this is an operation that is in evolution, and thankfully we're going to see. 5 years from now, it's going to look even different than it does now. It'll be easier to teach, easier to do. It'll become more mainstream, and hopefully it'll be better for patients. I have a question, just to say for the heck of it. But so, Dan, what do you think about the potential for the future of transurethral robotics in this space? So, the Virtuoso system or technologies that are going to go through the urethra, but will provide two effectors or 5 degrees of freedom or something like that. You see that in the future for your business?
Certainly, right now, that's not an option at all. There are people who are doing robotic hold-up, and I think that part of it is sort of the AI learning of the correct planes. There is some artistic latitude that you can have as a surgeon that the robot has not figured out, and maybe one day it will. Certainly, there are advantages of you wouldn't need millions of surgeons that are proficient in some of these different ways. And so I think it's a fantastic idea. I just have a hard time imagining that it's going to be as good as I would like it to be.
Thank you for tuning in for part 1 of Redefining Access, Single Port Robotics in Urology, featuring Dr. Richard Link and Dr. Dan Gralnek. You're listening to Innovations, and I'm your host, Dr. Ali S. Antar. I want to thank our producer and editor, Sandra Miller, and our department chair, Dr. Stephen Nakata. Thanks for tuning in.
WInnovations is a production from the Department of Urology at the University of Wisconsin-Madison School of Medicine and Public Health. Thanks for listening.